Thank you, Rick, again. And now we move to the second speaker, talking about germ cell tumors in children with Professor Tad Tomita. Actually, Tad is a great friend and is a giant professor in neurosurgery pediatric field. He's currently a Yeager professor and director of Falk Brain Tumor Center and Robert Lurie Children's Hospital, professor Department of Neurological Surgery at the Northwestern University Feinberg School of Medicine in Chicago, Illinois. The education and degrees Professor Tomita had started in 1966 in the medical school at Kobe University in Japan, and his residency was at the International Hospital in Northwestern University McGough Medical Center in Chicago, in Illinois. Professor Tomita worked as an associate professor of surgery at the Northwestern University, and he has been the division head of pediatric neurosurgery and vice chair in the Department of Neurosurgery at the Northwestern University Feinberg School of Medicine from 2001 till 2019. Professor Tomita had over 265 original articles in referred journal and 46 books and chapters. And the committee membership, he has been the co-chair of the ISPNO and the ISPN Education Committee chair from 2006 till 2010, and the ISPN president from 2011 till 2012, and now an ISPN historian. Also, Professor Tomita has been an editorial board member in the Pediatric Brain Tumors, editor-in-chief in the Journal of Neurosurgery Imaging and Techniques, an editor-in-chief in Neuroscience Discovery, and associate editor in the Child's Nervous System. So Tad is very well known and one of the giants who have paved the way for many pediatric neurosurgeons in the field. And I guess we will have great experience from listening to his interesting lecture about germ cell. Please, Tad, can you share your screen? Yeah.
There you go. It's come out? No?
Not yet. Take your time.
Or maybe share. Here.
There you go. There you go. Right.
Oops.
Perfect.
Thank you so much, Mohammed, inviting me to this wonderful opportunity. And I'm talking about this germ cell tumor. Germ cells are biological cells that give rise to the gamete, the future sperm and ova. But we don't know why it happens in the brain. And just briefly, histogenesis is very important to understand what's going on. So-called primordial germ cells originate in the posterior epiblast in the pre-gastration, the embryos, invading through the hypoblast and reach to the yolk sac at the 3rd to 6th weeks of gestation. And then they migrate from the fetal yolk sac through the dorsal mesentery of the hindgut to the gonad ridge, and there it starts to proliferate. There subsequently it stops. And then the primitive yolk sac also recedes. Now, migration of these germ cells, there's a couple of theories. Probably they go through blood-borne, through the newly formed blood vessel, and extravasate at the genital ridge, or along the sympathetic nerve fibers toward the genital ridge. And now, brain supposed not to have this kind of germ cells. Now, why it happens? Perhaps still we are not sure the real mechanism. So, extragonadal germ cell migration may be a failure of the primordial germ cells to exit or stop at gonadal ridge and further extend to retroperitoneum or mediastinum, particularly to the thymus, and then further up to the brain. Or maybe downward, mismigrated premodal, the germ cells can extend to sacrococcygeal location. And those cells usually undergo apoptosis and go away, but some maybe stays quiescence condition. And now when the time arrives, particularly at puberty, the puberty is that the gonadotropin or gonadotropin release hormone become activated, and then those cells may wake up and start to act badly. Now, when you look at germ cell tumors, there's two main different types. One is germinoma, and another one is non-germinomatous germ cell tumors. And the embryonal cell carcinoma, yolk sac tumor, choriocarcinoma, teratoma, and the mixed germ cell tumors, they are the subclassification of the so-called germ cell tumors. So histogenesis, Taylor published this article in 1954. Probably that is a transformation of primordial germ cells that become the germ cell tumor. Another more recent theories are the stem cell theory. Probably embryonal stem cells are the origin of the germ cell tumors. Now, when you look at the molecular landscapes, particularly epigenetic investigation have been done, and germinoma is very likely originate directly from primordial germ cells. On the other hand, non-germinomatous germ cell tumors usually take place from pluripotential embryonal stem cells in the brain that likely endogenous neural stem cells, and they are the likely origin of primary CNS germ cell tumors. The embryonal carcinoma, which is essentially a counterpart of embryonic stem cells, and this should be the prototype of all non-germinomatous germ cell tumors. And that they then differentiate to yolk sac tumor or choriocarcinoma or teratomas. Now this is the summarized histogenesis of the germ cell tumors. Primordial germ cells probably the direct cause of germinoma, and the embryonal stem cell, the primary provide origin of embryonal carcinoma, and then extra embryonal tissue differentiation toward trophoblast would become the choriocarcinoma, yolk sac to the endodermal sinus tumor, and the embryonal tissues, ectoderm or endoderm or mesoderm, become the source of the teratomas. Now, it's quite interesting when you look at the histological feature to explain the types of the germ cell tumors. For instance, germinoma, this is large cells and so-called small T cells that present with the two cell patterns. And when you look at the large cells, that is a resembling of primordial germ cells indeed. Now, mature teratoma is three more well-differentiated elements of three germ layers, ectoderm, mesoderm, and endoderm. In a very rare occasion, we see a more advanced organogenesis in the tumor, and this could be a fetus in fetu. Willis in 1935, he theorized twinning theory. That means parasitic twin, and another one, mechanism may be highly differentiating teratoma. Now, mature teratoma, for instance, this 11-year-old boy presented with typical headaches and emesis, and there's a quite heterogeneous appearing CT findings, and you can see hyperdense, hypodense appearance, and this is MR. This patient had EBD, and at the same time endoscopic biopsy, which showed keratin debris and histiocyte and giant cells. Now you can see when you look at very carefully, there's already some rupture of the membrane, and it's turned out to be the keratin debris. And this tumor was resected, and pathology showed fibroconnective tissue and skin and mature cartilage and fatty tissue, and also intestinal and respiratory type tissue. And this is a benign mature teratoma. Other patient, this one, I had this 20 years ago. This is a 3-year-old girl with a visual loss and quite a large tumor. This is the CAT scans, hypo and hyperdensity, and large cyst formation. And I resected this tumor. It's turned to be a line of the teeth is sitting. Probably these are the multiple teeth. So this could be a mature teratoma with organogenesis. And this indeed had a much larger cavity I created after tumor resection. And this patient did not have any further recurrence over past 20 years. Now, how about immature teratoma? Often it's present within a mature teratoma, and they are incompletely differentiated or embryonal component, resembling a fetal tissue. Most common histological immaturity occur among the primitive neuroectodermal elements. So you can see the rosettes or a neural tube formation and so on. And some area, the embryonic mesenchyme, which has hypercellularity and also mitosis. So this is not necessarily a bad tumor, the essentially very primitive component within mature teratomas. On the other hand, some teratoma can transform malignancy. I think somebody's talking. Now, immature teratoma, for instance, this is a 20-month-old baby boy with emesis for 3 weeks, and this is hydrocephalus, a large tumor. ETB showed negative for HCG, yet serum AFP is elevated, and this was resected, and nice resection undertaken. And the pathology showed mature teratoma with derivatives of endodermal forming the intestine-like structure. That is probably very likely the cause of elevated AFP. Nothing's the cancer's component. So immature component resembling the neural tube within that. But about a year later, the patient had radiographic evidence of the recurrence, very small cyst formation in the third ventricle. This turned out to be a mature teratoma. And this patient, since then, over 4 years, did not have any evidence of recurrence without any adjuvant treatment. Now, this patient is different. This is immature teratoma with a malignant transformation. This 9-year-old boy with headaches and ETB and the biopsy was done. This is a tumor in a pineal location. And after the ETB and biopsy, the patient in 2 weeks, there's a rapid growth in 2 weeks. So this tumor was resected and larger tumor samples obtained. That showed immature teratoma with cartilage, mesenchymal tissue, and primitive neural elements. Now, about 6 months later, or maybe actually 3 months later, the patient showed some evidence of the disease. And this was biopsy, and it turned out to be a mature neuroepithelial tumor. But about 8 months later, the scan showed concerning abnormalities. And after the resection of the tooth mass, it turned out to be a PNET. And the patient needed subsequent oncological treatment with craniospinal irradiation together with chemotherapy. But the patient is still alive. This embryonal carcinoma is quite interesting. This is found usually together with within the mixed germ cell tumors. They is probably the most aggressive component of the mixed germ cell tumor. This is very interesting because that replicates the structure of the early embryo, so-called inner cell mass of the breast site, breast cyst or gastrula, like this, and forming so-called embroid bodies consisting of germ discs, and also some attempt of the formation of the amniotic cavity like this. So this is an extremely primitive the tumor. Now, yolk sac tumor, so-called endodermal sinus tumor, is representing the yolk sac endoderm. And histologically, there's a lot of myxoid matrix resembling the embryonic mesoblast. But the interesting part is Schiller-Duval body, which is the essentially tumor is forming perivascular rosette-like appearance. And surrounding is a attempt of the formation of the yolk sac, and that is compressing outer layer, which is also flattened the tumor cells. And this is AFP stain is positive, and this is one of the hallmark of yolk sac tumor. Now, choriocarcinoma, this is extra-embryonic differentiation along the trophoblastic lines. They are cytotrophoblast and syncytial trophoblast giant cells. And on this image, you can see it's a pale tumor cell that is a cytotrophoblast, and darker one is a syncytial trophoblast. And this is surrounding the cytotrophoblast area. That is a reminiscence of the arrangement of the placenta. And also another important character of choriocarcinoma is their vascularity. There's a very ectatic vascular channels and blood lake, and also evidence of the hemorrhage. And it's a histochemical study stain showed the HCG staining in the cytoplasm. So this is one of the examples of hemorrhagic choriocarcinoma. It's a very rapid growing. This is only 10 days apart, CAT scans. This is a very old scan of mine. This is choriocarcinoma. Now, how are the mixed germ cell tumors? And this is a combination of variety of cells and also expression of the tumor markers. For instance, this patient had a disseminated germ cell tumor with elevated beta HCG. We did not do any biopsy. This patient had a very high HCG. Therefore, the patient was treated with ifosfamide and BP16, and the tumor was completely melted away. So we don't have any histological confirmation what this tumor looked like. How about another one here? This is a 19-year-old boy with double vision, and there's a very high elevation of the tumor markers. And the endoscopic biopsy showed a mixed germ cell tumors with yolk sac and choreo component, and AFP and HCG keep climbing up before the treatment. And then the patient received the chemotherapy, and then this tumor is totally resolved. And this patient had a small residual here like this. So this residual underwent the so-called second look surgery, and benign epithelial tumor component was noted, but there's no yolk sac or choreo component. And all those tumor markers normalized after the induction of the chemotherapy. Now, for statistical purpose, age is very common, somewhere around late teens, around mid-teens is probably the peak in the pediatric population. But another peak happens in a very early stage of life. Now, male to female ratio is 4:1, and according to the statistics, this is more common among the Far Eastern, like Japanese and Korea, probably 5 times more than the USA or European counterpart. But this is interesting. Caucasian group, gonadal germ cell tumor is much more common than Japanese group, almost 6 times more. Now, the location of germ cell tumors happen on pineal location, suprasellar or basal ganglia. Intracranial germ cell component, this is the most common site. But in the young, like infant to sometimes newborn, they may present with whole hemispheric tumor like this, or posterior fossa, and or else sacrococcygeal tumor. This is probably not the neurosurgical disease unless the tumor extends into the spinal canal, which is relatively uncommon. Now, based on our statistics, the solitary, so-called among the 84 intracranial germ cell tumors, the solitary pineal location was 50%, which means the rest of them is somewhere else. Solitary suprasellar location was 26%, about 1/4, and 20% is bifocal, which affect the pineal and suprasellar location, and the basal ganglia is much less common. Now, when you look at germ cell tumors in the central nervous system, pure germinoma is about 2/3, and non-germinatus one is 1/3 of the cases. And the germinoma tend to occur in the suprasellar, basal ganglia, or the older patient group. On the other hand, non-germinatus germ cell tumors usually happen in the pineal and the younger children. This is my own data of the past 20 years. The germinoma, this is pineal germ cell tumors. Pineal location, germinoma is about 55%, and the so-called teratoma is a part of the mixed germ cell tumor or pure teratomas, about 1/3, 32%. And the rest of them minor pure choriocarcinoma, embryonal carcinoma, and yolk sac tumors. On the other hand, suprasellar germ cell tumors is a germinoma, or including suspected ones, much more common. Almost 80% of suprasellar germ cell tumors are germinomas indeed, and much lesser degree, about 20%, so-called mixed malignant tumor, germ cell tumor, or non-germinomatous germ cell tumors. Variety of symptoms, but naturally they are related to the location of the tumor. Pineal tumor tend to present with hydrocephalus. The suprasellar one is almost always present with diabetes insipidus. Sometimes we call occult suprasellar germinoma, together with other hormonal or visual symptoms. The bifocal one is a combination of those two. Basal ganglia and thalamic the germ cell tumors tend to present with progressive hemiparesis or behavioral changes. And the precocious puberty is relatively uncommon, but usually related to some increased the production of the HCG. For instance, this young boy, 4-year-old, calcification in the center, which is supposed not be there, presented with 5 days headaches. So I did ETB, but nothing extraordinary. And that was March of 2011. And following the ETB and Omaha reservoirs, the patient very rapidly developed precocious puberty. And MRI showed increasing mass, like a cystic mass together with solid component. And at that time, the patient showed CSF, beta-AC 70 and serum 182, negative AFP. But serum cholesterol is quite high. And testosterone level is quite high. Now, this patient received the chemotherapy, and then beta-AC dropped down, but it's still persistent disease. So I did the craniotomy, and I resected this teratoma, And it's found to be the pure teratoma without the other the malignant features. And this patient subsequently received the radiation therapy and has been well almost 9 years now. Now, those patients present with hydrocephalus and particularly in the pineal location. But diagnosis-wise, when we do a history and the physical, the patient, the age and sex is very important. I have never seen the female pure pineal germ cell tumors except for one. And this is quite unusual to see the germinoma in the pineal location. Of course, we obtain advanced neuroimaging and tumor markers. If the CSF is available, make sure we get tumor markers and the CSF cytology, and ultimate diagnosis probably require the surgical biopsy. Now, I do not get into the differential diagnosis. Pretty much everybody knows about it. So once we identify, we obtain the neuroimaging, usually obtain the CAT scans. I always obtain CAT scans to see calcification or hemorrhage in addition to MRI. But MR should include the spine MR as well. Now, calcification, as the last patient, 4-year-old boy with calcification, it's normal after 6.5 years. So first 6 years of life, should not be a calcification in the pineal gland. So if you see that calcification in that group in the pineal gland, you have to suspect there's something going on, particularly the tumor. Now, the bifocal germ cell tumors, we see more and more these days because we pay attention to read, make sure there's nothing going on in the hypothalamic location or the pituitary stalk. So we have to be analyzed very carefully about this. Sometimes patients present with a disseminating appearance like this. Now, tumor markers, AFP and beta HCG we obtain essentially very routinely. And the alpha fetoprotein, its half-life is 5 days, and beta HCG is only 1 day for the half-life. So it's very important to know what the half-life look like. Once you treat it, you have to get the idea when that's supposed to become normalized. The AFP can be produced by yolk sac endosome, fetal hepatocyte, or embryonic or intestinal epithelium. So the younger age, so-called immature teratoma, can produce that AFP, even though there's no yolk sac component. Beta HCG is usually produced by syncytial trophoblast. Other placental alkaline phosphatase or soluble kit, they, of course, we don't have any commercially available kits yet, but if you do have some special lab, we can measure those placental alkaline phosphatase and the soluble C kit. So when you do those tumor markers, AFP and beta HCG, you have to send both serum and CSF because AFP tends to be higher among the serum sample. On the other hand, beta HCG appears to be higher in a CSF sample. So we have to combine those two. Now, because of most of the patients present with hydrocephalus among the pineal tumors, usually we do biopsy at the time of ETV. And if you do have don't have any flexible scope, you have to change the trajectory, like this patient. Sorry, here you go. Now, I cannot understand why. So I cannot produce that video in here. But anyways, when we do the biopsy, and if we do have a flexible scope, you can do a ETB first, and then turn the angle, and then take the sample of the tissue out from the posterior third ventricle. But the caveat is we have to make sure that this tumor is not too vascular, which sometimes we don't know because we don't do the angiogram. This is the angiogram which was done about 30 years ago. We still did the angiogram at that time, and it's kind of scary to see this kind of vascularity of this mixed germ cell tumor. And even though there's no conventional, the case of germinoma, sometimes it can cause hemorrhage. This patient developed some hemorrhage at the recovery room, although at the time of biopsy, there's no hemorrhagic events, but this patient became very sick because of hemorrhage at that time. Now, hydrocephalus management, usually we try to avoid the shunt because creating a shunt dependency on the CSF seeding of peritoneal space. Since we use that chemotherapy these days, it's relatively unusual to see the CSF dissemination, but I have seen way before the chemotherapy became popularized. And also in a place that shunt, it's maybe very difficult to attain that brain relaxation. Now, the southern ventriculostomy become very popular, but what shall we do when the patient has a hydrocephalus with a bifocal disease? It's very difficult to do this ETV with a large mass setting in a tubular scenario. We found that this tumor, particularly germ cell tumors, tend to respond to the use of dexamethasone. For instance, this patient had a large tumor, hydrocephalus, and the patient at that time, it was popular to do the EBD, and then we did this one. After the use of 3 days of dexamethasone, the tumor become maybe half a size, and this patient end up don't need any shunt. So this is one of the ways we may temporalize hydrocephalus by the use of decadron, because germinoma tend to have multiple the T lymphocytes, and that respond to the use of steroid. Now, teratoma is quite resistant to chemo and radio treatment, and naturally those are the surgical candidate. Germinoma is extremely sensitive, and sometimes to the steroid as well. But the malignant germ cell tumors are often sensitive to chemo and radiation treatment. Now, treatment principles like this, based on that, teratoma needs a surgical resection. Germinoma is not surgical disorder, except for the potential biopsy. And those patients are treated with chemotherapy and the radiation treatment. Malignant germ cell tumors, chemo up front, and then secondary surgery, and remove the potential teratoma component, and then start to consider the radiation treatment. Now, pineal germ cell tumors, surgical approaches are practiced multiple ways, as occipital transtentorial approach, infratentorial supracerebellar approach, transcallosal, either transcranium, interpharyngeal, or subchoroidal approach, and so on. There's a lot of approaches. I think I prefer that as occipital transtentorial approach because of comfort. This is another common approach people use, infratentorial supracerebellar approach. And exposure is probably about 4 centimeters sideways. And then surgeon's comfort. I think this is probably most important, because most of the time we have to bring the patient on a sitting position, and the hand become very tired. And also you cannot use the assistant because you're taking up all the surgical space with both hands. The veno garden is above the tumor, and blind spot is a supratentorial component. But some people claim that this midline tumor, so midline approach, like infratentorial supracerebral approach is the best. I do not dispute that claim, but the placing the patient on the sitting position and also comfort and also availability of the assistant hand, I prefer to use occipital transtentorial approach. For that, usually patient is placed on a prone position, hockey stick incision, and then the either right or left side approach to the tumor. Now, in posterior interhemispheric approach is more appropriate because there's no bridging veins on the back and nothing to transect neural structures like splenium and also blood vessel. Even though you do the surgery, you don't see the precentral vein because you are slightly off. So it's relatively unusual to cut the precentral vein. And the vein of Galen is directly, you can see it and you can protect it. Posterior transcallosal approach, this is Dandy's approach. Still, some people use it. I have used only a couple of times of this, but it's very uncomfortable because essentially going through those cortical veins is really killing me. Now, how about transcallosal interpharyngeal approach? Usually in a pediatric population, still cavum, septum pellucidum is still available like this patient. So you can go through it. In this particular case, there is no space between the vein of Galen and tectum. So this patient was approached from the more frontal interhemispheric transcallosal approach through the cavum. But most of the patient, pineal teratoma, need much major operations. And germinoma is extremely chemosensitive. Therefore, we use that once diagnosis is done based on the CSF, beta ACG, usually we do the ETB plus minus of biopsy. But if you do have a CSF sample, and there should not be the beta ACG in the CSF, even though it's weakly positive, I would treat the patient as a germinoma with chemotherapy. And most of the patients respond quite well. Now, how about this patient who had elevated AFP? And this is patient, we don't do biopsy, just give chemotherapy. And this tumor become densely enhancing mass, become very subtle residual mass. And this was done after the ETB and Ommaya reservoir placement and chemotherapy. Serum AFP dropped from 60 to 1. And then this residual tumor was resected. And as we anticipate, this turned out to be a mature teratoma. On the other hand, some tumors don't respond to chemotherapy, like this 18-year-old, very bright Northwestern student came over here with double vision like this. And AFP is high, HCG is also elevated. So probably mixed germ cell tumor, but unfortunately, the patient did not respond. Therefore, the tumor was resected through occipital transtentorial approach. And I'm sorry, I don't produce that video in here. But it's turned out to be the yolk sac tumor embryonal carcinoma component, and but the majority of the tumor was the teratoma, and this tumor was resected in total. The choriocarcinoma, this is a 17-year-old boy with emesis and headaches for 10 days, and it's clearly showed hemorrhagic in nature, hyper-intense, and probably best one is a GRE or SWI imaging. This clearly showed the hemorrhagic nature. Usually, you can conclude that this is pretty much the choriocarcinoma. Therefore, the patient was treated with chemotherapy and then reduced the size somewhat, and then after second look surgery. But this patient, unfortunately, recurred and clipping up a beta ECG, and ultimate patient died. This is one of the rare ones we lost. Now, growing teratoma is a concept that you have to remember. The normalization of the previously elevated tumor markers, yet tumor continue to grow during or after the chemotherapy. Those are the essentially mature teratomas without any non-geminomatous component. For instance, this 11-year-old boy with headaches, large mass, this T2 weighted image, and AFP is 7, serum is high, and he was treated with chemotherapy. Serum level went down to 5 from 264, but tumor continued to grow, particularly cystic component. This turned out to be a mature teratoma. And after resection with this tumor, the patient did not have any recurrence after radiation treatment as well. Now, supracellular germ cell tumors, 80% are germinomas, and some are multifocal, often with a pineal location. And this type of tumor can disseminate to the ventricle much more than the pineal tumors. And the cavernous sinus is involvement is noted, 5 out of 42. Now, diabetes is a very cardinal feature of the presenting symptoms. Almost always those patients has evidence of diabetes. And also the hydrocephalus is much less common if you compare with pineal tumors. And sometimes those patients has a history of the diabetes insipidus, probably 2 or 3 years. For instance, this kid had 1.5 years history of DI, and this prominent pituitary stroke was overlooked in December of 2005, but continued to have diabetes, and follow-up scan showed the clear evidence of the tumor growth. And then this tumor was responded quite well to the treatment of the chemo. Now, this patient had so-called cavernous sinus extension with a 6th nerve palsy, and the 3rd nerve palsy with a double vision. And this kind of case is simply we can do transsphenoidal and nasal biopsy. For the sake of the time, I just skip this case. Now, how about the supracellular yolk sac tumors? This 11-year-old girl is very high AFP in both serum and also CSF. Chemotherapy was used, and very small residual scarring-like appearance. And at second look surgery, pituitary stalk is intact. You can see small cystic formation. It's turned out to be only fibrous tissue, and this patient showed essential resolution of the mass after the chemotherapy, and subsequently the patient received radiation therapy, and almost 15 years, she's a school teacher now, without any recurrences. This is a more recent patient. This is a very large subventricular cystic mass. This is treated with transventricular approach. And initially, I thought this must be a teratoma, but he did have the teratoma with germinoma and the yolk sac component, but the majority were benign teratoma. But this patient required oncological treatment. Now, when you look at the bifocal germ cell tumors, most of the pineal and the bifocal tumors occur among the males. On the other hand, supracellular mass is more common among the female. And diabetes insipidus bifocal tumors, if singular, so-called singular supracellular germ cell tumors almost always present with DI, but about 3/4, 75% of bifocal tumors present with diabetes insipidus. Now, still we are not sure the mechanism of bifocality of germ cell tumors in both pineal and hypothalamic location. Maybe a concurrent occurrence. Still, it's very hard to understand this concept. How about CSF dissemination, or maybe subependymal direct extension? For instance, this 14-year-old boy with evidence of multiple mets, this is bifocal disease, the tubus, the pineal location and supracellular location, but also there's forced ventricular evidence dissemination on the MRI. So this is treated with initial chemo and both regions melted away. So could be a CSF dissemination. When you look at this recent publication by Homeland, this is just looking at CSF flow through the third ventricle. There is supracellular cistern to a synedium location or pineal location, the flow is diminished. So this area, particularly supracellular, the tubosynedium location, infundibulum location, maybe a kind of stagnant through CSF circulation. Maybe that's the reason why the second lesion may occur. But on the other hand, those patients, particularly germinoma, tend to have this very typical appearance of germinoma, kind of creeping along the wall of the third ventricle. And at the time of the endoscopic procedure, you can see kind of thickened flow of the third ventricle. So this could explain so-called subependymal extension. Now, how about basal ganglia gut germ cell tumors? This 11-year-old boy with 3 weeks history of hemiparesis, anorexia, and asthenia. And this is a kind of ill-defined appearance, but please note ipsilateral cerebral atrophy. And this has been well documented in the literature, perhaps some axonal degeneration, which means must be a very chronic disease process taking place. But this patient had positive CSF cytology. As you can see, that the lateral ventricle had some tumor, and this turned out to be a germinoma, and that was treated accordingly. For the sake of the time, I just skip this. Now, adjuvant therapy, of course, chemotherapy is very important, and now people use carbo, BP, and ifosfamide combination. The radiation therapy, initially, the patient received craniospinal axis radiation that changed the whole brain, and then diminished to the limited or so-called involved field radiation. And now, most of the people use the whole ventricle radiation treatment. Now, this was justified by 2 groups, the French group and also American CNS group. Both showed involved field radiation therapy, it tend to fail, and the limited field or involved field radiation therapy failed. Therefore, a more recent COG study for the localized germ cell tumor treatment, for instance, this is the non-germinal germ cell tumor treatment scheme. Radiation is used for whole ventricular irradiation after 6 cycles of chemotherapy, alternating carbo BP and ifosfamide BP combinations. For the germinomas, this is the same thing, whole ventricular irradiation after 4 cycles of carbo and BP pre-radiation chemotherapy. But you have to remember, these are so-called localized CNS germ cell tumors. So I think they did a very good job. This is a recent publication based on this ACNS 1123. That means the whole brain radiation, 30 gray, and additional tumor boost to where the tumor was, like a pineal or supracellular, and attained quite good survival, almost 90% recurrence-free survival for 3 years. The similar publication was made from the PSYOP, and they also noted the focal radiation field are sufficient, but this is misleading. This should be a whole brain radiation, or correction, whole ventricle radiation treatment. So in conclusion, still we are not 100% sure what is histopathogenesis. There's a lot of research has been done, particularly using the epigenetic studies with molecular biology, and we know more in the next few years. And histology is so important, and particularly tumor markers dictate what kind of treatment we should provide. Surgical resection, teratoma and immature teratoma, certainly the surgical candidate, but the mixed germ cell tumors, usually we recommend the second look surgery to make sure there's no residual radio resistant mass such as teratomas. And also we found that the great majority of germ cell tumors are oncological disease, and we need a lot of help from our pediatric neuro-oncology group. Well, thank you very much for your attention.
Thank you, Ted, for this nice and very illustrative and detailed presentation. Very interesting. And does anyone have questions? John, do we have any question?
Yes, I believe Uday. Go ahead, Uday. You can come on in and ask your question. Uday, go ahead. We're not hearing you, Uday. I guess the audio is not working. Can you type your question in, please, Uday? Because we're not hearing you. And back to you guys. I don't know if there are other questions or comments. I'll try to get Uday's question when he's typing it in now.
Okay. So I just want to ask you, Ted, in case of a mixed germ cell tumor, the mixed type, when you have start with the chemotherapy and you have normalized the tumor markers, do you go again for a second look surgery, or you go directly for another session of chemotherapy first if you still have them not normalized? If you have the markers still high.
Yeah, if indeed there's a protocol set for the so-called germinoma, this is 4 cycles, and non-germinoma, germ cell tumors, we use 6 cycles. And if indeed there's a persistent disease, either radiographic evidence or persistently elevated germ cell tumor markers, I would recommend to do the second look operation and take a look at it and what component of the mass is indeed present. So, but it's the most of the time, the tumor vascularity is also much diminished together with the size of the mass. So second look surgery provide much better safe net for the operating surgeons.
Yeah.
Okay, we have a question from who? We have a question from Uday. Well, Uday says, is there a change in the pattern of drug delivery in the form of nanotechnology? Is it improving outcomes? In other words, is nanotechnology improving the outcome of drug delivery?
Yeah, it's a Northwestern has a big nano center, and they are doing a lot of the new drug delivery method, but I'm not aware of new thing going on specific to germ cell tumors.
Okay, thank you.
Okay.
Yeah.
Good. Ted, so I see you still sharing your screen. If you
I'm sorry.
Yeah, I can get that off. I can stop it. Okay. I got it.
Oh, stop share. Okay, here you go.
Okay.
Sorry.
I got it. Okay, there you go.
Okay, thanks, Dad. That was just a fantastic overview, and clearly you've built up a huge series. I mean, these sorts of tumors tend to predispose in Asian groups. And did you see a lot of these in while you were in the States, or did you see a lot of them prior to moving across? Or did you find that balance between the geographic movement even or not?
So you have seen most of your tumors in the States, or you have seen them outside? That's the question there. Yeah.
Are you asking me?
Yes.
Yeah. I mean,
Yes.
with Asian predilection for germ cell tumors.
You know what? Actually Asian population is where I practice medicine in Chicago. Not many so-called Far East Asians. Occasionally I see the Koreans, and but the majority of the patient I deal with is American people. So I did not see any so-called racial thing, except for moyamoya disease. Moyamoya kid, we see a lot of Korean or the Asian populations still, but I did not see any tendency of American Asian populations.
Okay. No, thanks, Dad. That's a very useful point. Okay.